Bismillah ar-Rahman ar-Rahim. Distinguished guests, respected colleagues, esteemed speakers, and dear friends, it's both an honor and a privilege to welcome you all to the Breast Imaging Conference. Today, we gather with a shared mission to advance knowledge, strengthen collaboration, and ultimately improve the standard of breast care for women across our region. First and foremost, we extend our deepest gratitude to Almoosa Hospital for their generous support in hosting this important event. This conference would not have been possible without the vision and encouragement of the hospital's leadership. We would like also to sincerely acknowledge Dr. Mustafa Sultan, head of our radiology department, for his invaluable guidance, dedication, and tireless efforts in making this summit a reality. On behalf of the organizing committee, I wish you a productive and inspiring meeting. May this conference serve as a platform for learning, sharing, and building lasting professional connection that will positively impact our committees. Thank you, and welcome to Al-Ahsa.
Welcome to the stage, Dr. Mustafa Sultan. Dr. Mustafa Sultan is an American and Canadian radiologist. He's body MRI and IR consultant. He's acting as the group chief of radiology at the Almoosa Health Center. He's also the director of Azizia Center and Almoosa Health Group. Welcome.
Since we are beyond the schedule, I will go fast. I'll give you just snapshots of the epidemiological data of breast cancer in the Eastern Province with a little bit of comparison of the data from the Kingdom of Saudi Arabia. This is this data from a retrospective study for about 6,000 positive cases done between 2006 to 2022. Single center registry from King Fahd Specialist Hospital in Dammam. So we're talking about تقريبا more than 10 years from single hospital. We can see, interestingly, the distribution of positive breast cancer in the Eastern Province. 30% of the total positive cases are in Al-Hassa, which is this region. So this is #1 incidence rate in the Eastern Province. And regarding the disease stage, initial stage distribution, we see regional and localized are the dominant. The age distribution, interestingly, the left side from the Eastern Province and the right side from the national data from Saudi Arabia from 1990 to 2021, we can see the dominant age distribution is from 30 to 50. Which is bring the breast imaging into a continuous dilemma on when we start the screening, basically. Again, this is matching almost on the right side, the national data across the Kingdom of Saudi Arabia, which is always a debate on what is the proper age and what is the proper modality to start the screening, especially in that age group. We see the densest breast and the, so this is the data about the age distribution. The projection, we can see the black line is the current data and the estimated economical projection over the next almost 10 years. We will continuously see the positive cases increasing, and this is based on the economical evaluation. This brings me to the concept is, are we doing enough? Do we need to invest more in the manpower and the equipment and the facilities of breast cancer? And definitely we need to consider that. And we can see that the incidence over time is stably increasing, but luckily in the right side, the mortality rate is decreasing over time. This is the national data from Saudi Arabia, and we can see the top few lines are the younger age and the bottom few lines are the older age. Meaning nationally over the Saudi Arabia as well, everybody is suffering that breast cancer is almost becoming the disease of young age. I will skip this one. I will skip that one. Question to the audience. You are all expertise. What is your main focus in regards to the outcome as healthcare provider when dealing with the breast cancer patients? What is number one that we want to achieve? Huh? Cure. Early stage, cures, early detection, better outcome, better clinical outcome. All of us are talking about the disease burden. Detection, metastasis, staging, response, partial response, complete response, and recurrence. Unfortunately, all the healthcare providers, including us, are talking about the disease from one single angle, which is the disease burden. But there are another arms that usually unmeasured in our day-to-day practice. The two major concepts gaining publicity now, DALYs and QALYs. Quality adjusted life years is the QALY. Disability adjusted life years is the DALYs. I will come to that concept a little bit. Quality is the health gain from the intervention, which means the lived year in a good health after the intervention. So the quality of life after the intervention. The higher the value is, the better for the patient. DALYs, which is a disability adjusted life years, is the burden of the disease on the patient. It means the total loss of the healthy years due to premature death or disability. If we go back, most of our incidence of the disease is for younger age, so it affects definitely both. So higher quality is better, less disability measures is better. So QALYs focus on the positive impact of the health intervention. DALYs focus on the negative loss of health from disease. DALYs, for example, this is a brief explanation, which is equals year lived in a disability plus the life lost, which is death. And most of our patients in the young age, both parameters are severely affected. Why I'm mentioning that? All of us are focusing on one single arm, which is the disease burden, and our process design, infrastructure design, the expertise hired. We are focusing only on the disease burden, and we ignore a very subtle component in the patient journey with that ugly disease, which is the quality of life and disability associated with it. This is, for example, a list of QALYs usually that we need to measure, which is called PROMs, patient-reported outcomes. And we can see now that there are many components that should be measured during the patient journey in order to improve the quality of life after the intervention. And that makes the decision of intervention based on the disease itself, as well as the patient wish of which quality parameters she want to preserve or improve during the treatment cycle. We can see, this is from Saudi Arabia, we can see the black line that the DALYs is decreasing over time. So the mortality is decreasing, but the disability is decreasing as well. Shukran.
Thanks, Dr. Mustafa, for this informative review of the data and the statistics that we are standing in. Next, please welcome to the stage Dr. Ala Al-Maimouni. Dr. Ala is the head of women's imaging and consultant in breast imaging at King Fahd Military Medical Complex in Dhahran, Saudi Arabia. She is board certified in radiology and completed her fellowship at the University of California, San Diego, USA, with extensive expertise in diagnostic and interventional breast imaging. Dr. Ala is dedicated to advancing women's health through excellence in clinical care and education and research. Welcome, Dr.
Thank you. Assalamu alaikum. Thank you, Dr. Moran, for this beautiful introduction. Today, I'm going to speak about the screening method in dense breast. This is my disclosure and agenda. And we'll talk about the 2D mammography. Mammography is the only image modality proven to reduce the breast cancer mortality. The greatest benefit is observed when the annual mammography begins at the age of 40 years. And not all the women benefit equally from mammography. It depends on the breast density. So what's the breast density? The breast density refers to an amount of fibroglandular tissue relative to fat And it's matter because it's lower the sensitivity of mammography and increase the risk of breast cancer. The BIRAD 5th edition delineates the 4 category of breast density, and we will focus on category C and D, which referred as a dense breast. The detection challenges. Breast cancer and dense tissue are both radiopaque in mammogram. Dense breast tissue can mask or obscure the non-calcified cancer, reducing the mammographic performance, which with increasing the breast density, the sensitivity of mammography drops from as high as 93% in fatty breast to as low as 30% in extremely dense breast. The number of false positive results increased from 11 per thousand examination in fatty breast to 24 per thousand examination in extremely dense breast. Increased breast cancer risk, coupled with the fact that the mammography does not benefit women with dense breast equally, had led to interest in supplemental screening. So, American College of Radiology recommend that women with a dense breast may offer a supplemental breast cancer screening on the basis of individual risk factor, but the modality or interval of supplemental screening is not specified. The first modality is the digital breast tomosynthesis, which is a digital mammographic technique in which multiple angle low-dose projection image are acquired and reconstructed into the thin, typically 1 millimeter almost sizes. The primary limitation of 2D mammography is that the dense breast can mask the non-calcified cancer, as we mentioned before. Tomosynthesis can be used to address this limitation. To provide a detailed image in the breast tissue with a multiple angle. So there is, of course, in each modality, strength and limitation. The benefits of tomosynthesis include its ability to better show invasive cancer, especially lobular carcinoma, and to reduce the recall rate after the screening mammography. Tomosynthesis improve the conspicuity of architectural distortion, which have high rate of malignancy and can be easily missed at 2D mammogram. The main interpretation time for mammography with tomo is twice that of 2D mammography, and this is a disadvantage for that modality. Here an example. I wish I have a marker, but I don't have, unfortunately. For 2D mammogram with a heterogeneously dense breast, with no abnormalities detected in that study, while in tomosynthesis we can see irregular mass with a speculated margin. Another example, patient came with a localized pain. As you can see, the triangular skin markers seen with underneath focal asymmetry or increased glandular tissue. Not very good into the mammogram, but when the patient did the tomosynthesis, it showed more details for the lesion, shows the irregular mass with a speculated margin. Patient came with a nipple retraction only. 2D mammogram was negative. Tomosynthesis here show some architectural distortion. Targeted ultrasound was done for this patient and revealed an irregular heterogeneous, irregular hypoechoic lesion. Biopsy was done and revealed IDC. These cases illustrate the superior sensitivity of tomosynthesis as compared to the mammogram. Other modality is supplemental screening ultrasound in patient with a dense breast tissue has shown the allowed detection of the small invasive non-negative breast cancer not seen in mammogram or clinical examination. The strength of ultrasound has become a widely adopted tool because this modality is relatively affordable, and there is no radiation or no contrast material. Final assessment can be made by the radiologist, giving the patient as a BIRAD 4 or 5, so patient does not need to be recalled for additional imaging. The primary drawback are the ultrasound has a low positive predictive value and high rate of negative biopsy, result which may not be cost effectively effective over the time. 8% of the breast cancer are occult and ultrasound and mammography. Ultrasound feature of a breast cancer and dense breast are similar to those fatty breasts. We can see it as a hypoechoic, speculated, angular margin, and sometimes or less commonly, we will see breast cancer as a hyperechoic in ultrasound. As in this case, a patient came to the ultrasound and shows an oval hyperechoic lesion with a circumscribed margin anteriorly with indistinct margin posteriorly. Sagittal MR was done and shows irregular enhancing lesion. Biopsy revealed an lobular carcinoma. Another case, patient came with a localized pain marker, as we can see in the two images in 2D mammogram and tomosynthesis with no abnormalities. Targeted ultrasound was performed and revealed an irregular hypoechoic lesion. And biopsy done, and it was a malignant lesion. Contrast-enhanced mammogram is emerging modality that incorporates functional data into the mammogram, revealing abnormalities that are difficult to interpret at 2D mammogram or tomosynthesis due to the overlapping of breast tissue. So CEM shares most accepted indication with the breast MRI. Multiple studies have shown that the diagnostic performance of CEM to be similar to the breast MRI with a similar sensitivity or slightly higher specificity. CEM is significantly more sensitive than 2D mammogram in women with dense breast with a higher sensitivity. When ultrasound was used to supplement negative contrast-enhanced mammogram examination, no benefits were discovered. So, contrast-enhanced mammogram will provide an advantages over the MRI, including more affordable and available. Women who cannot undergo MRI due to the claustrophobia or metallic implants can safely undergo the CEM. Another advantage of CEM over MRI or ultrasound is the ability to direct correlate area of enhancement with the mammographic abnormalities. CEM may be advantageous over the MRI to expedite the additional staging workout. It may be combined with the same-day ultrasound examination, biopsy, although the workflow challenges remain. So, what is the workflow challenges in CEM? The potential for reaction to contrast material, increased radiation exposure, lack of 3D imaging are the main disadvantage of the CEM. Venipuncture will result in longer appointment times, and physician should be present to manage any reaction. Malignancy at CEM is most associated with a mass with low energy image that enhance a recombined image, as we can see here in the right hand, avidly enhance irregular mass with minimal parenchymal enhancement. This patient came for screening with extremely dense breast, showing a scattered calcification in 2D mammogram. Tomosynthesis was performed and revealed a subtle architecture, as you can see in that two image. Contrast enhanced mammogram in the below images show irregular enhancing mass with a speculated margin, giving more details for the lesion. Ultrasound was performed and revealed an irregular hypoechoic lesion. Biopsy was done and revealed a malignancy. Also, this is another example for patients with extremely dense breasts. A group of amorphous calcification are noted in the 2D mammogram, while in the contrast-enhanced mammogram shows an irregular enhancing a lesion at the site of calcification with more details and extent of the disease. The ability of CEM to allow the detection of additional tumor foci in the ipsilateral or contralateral breast, as we can see here, 2D mammogram show speculated high density mass in the right breast, while negative in left breast. In contrast, enhanced mammogram, there is an irregular enhancing mass corresponding to the one we mentioned before in mammogram, but in the left breast, there is an unmass enhancement not seen in 2D mammogram. Last modality with us is the full abbreviated breast MRI. Has a superior cancer detecting rate when combined with mammography compared with that with other screening modality, particularly in women with dense breast. MR is considered the most sensitive modality, detective invasive breast cancer and DCIS. Recent ACR recommendation includes supplemental MR for women with a personal history of breast cancer and dense breast. The positive predictive value and false positive rate of supplemental MR are better than those with supplemental ultrasound. Important advantages for breast MRI is the superior sensitivity, its ability to show detailed 3D of the breast, chest wall, axilla, and give us more information about the tissue composition and vascularity. No radiation exposure there. It's aid to differentiate the benign from malignant lesion. Abbreviated MRI as advantages due to the shorter examination time. This will reduce the cost. And similar clinical performance to the full protocol MRI despite the limited sequences. When compared with a supplemental ultrasound, the cancer detecting rate have positive predictive value and the false positive rate are better with for both MRI in dense breast. Full protocol. So now we are talking about the disadvantages. The full protocol dynamic contrast enhanced breast MRI is limited by lengthy examination time and high cost. MRI required on-site physician cover for adverse reaction, contrast material, like an allergic reaction or extravasation. And contraindication, it is a contraindication in a renal dysfunction or a non-MRI compatible implant devices. MRI may not be feasible in patients with a high body mass index, claustrophobia, or difficulty lying prone. Here an example for a breast MRI. Axial post-contrast T1 fat SAT sequence and MIP projection revealed an indistinct enhancing lesion, which is not seen in mammogram. Another example for heterogeneous breast showing a partially obscured high density mass in the upper quadrant. MIP projection revealed an irregular enhancing mass corresponding to the previously mentioned in mammogram, but there is also variably size enhancing lesions denoting the multicentric breast cancer. In 2D mammogram, there is groups of pleomorphic calcification. When the patient underwent to the MR, revealed an extensive non-mass enhancement, and this findings illustrate how the MR superior sensitivity of the MR as compared to the 2D mammogram. So in conclusion, dense breast tissue is a commonly encountered diagnostic challenges that can negatively affect early detection of a breast cancer and outcome of treatment. Improving awareness and accessibility of supplemental screening will reduce the breast cancer mortality. All methods of supplemental screening can improve cancer detection and dense breast. Tomosynthesis provide a better spatial resolution than digital mammography, but has a limited efficacy in extremely dense breasts. Supplemental ultrasound will improve the cancer detection, but often associated with high false positive rates. MR offer the great sensitivity, but the cost and accessibility remain the challenge. Contrast-enhanced mammogram deliver a comparable diagnostic performance for vascular imaging at a lower cost and potentially greater availability than MRI. This is my references, and thank you.
Thanks, Dr. Ala, for addressing this topic, which has been addressed multiple times in international conferences. It's quite relative to our population, given higher incidence of breast cancer in early onset breast cancer relative to the international average. Next, please welcome to the stage Dr. Rasha Sarhan. Dr. Rasha Sarhan, she is a breast imaging consultant and interventionist radiologist at Asir General Hospital and leader of the breast cancer screening campaign in Asir region. She completed a fellowship in women's imaging at King Faisal Specialist Hospital in Riyadh. She holds advanced training from Harvard Medical School, Johns Hopkins University, and Hamad bin Salman College in Executive Education, Leadership, and Artificial Intelligence Breast Cancer Detection. Welcome, Dr.
Thank you. Thank you all. It's my honor to present with you in this conference with this distinguished breast imaging, and I hope my contribution meet your expectation. So my talk, it will be going basic in screening mammogram, what we can learn from breast cancer. Nothing to disclose. However, an introduction about screening program in Asir region. We have around 11 screening mammogram distributed along the region. They do around 15 to 20 per day. All of the screening mammogram were read in center. After that, by RAD 0, 4, and 5 referred to Asir Central Hospital, which me and my colleague, Dr. Thuraya, revised these cases, and all of the images will be from this data. As we all know, breast cancer or breast imaging plays a critical role in early detection and patient survival. Although we have a lot of advanced technology, we still have an issue picking breast cancer in its early stage. A study was done in 2020 in US in breast cancer malpractice litigation. It was a retrospective study. They took around 253 cases, and they have a lot of factors to study it. One of them is the delayed in detection. And unfortunately, radiology were the center of this breast litigation due to the rule in early detection and making accuracy in the time should be. So my objective, it will be to understand the factors that lead to missed breast cancer. And in between, we will see some of the cases that I have collected, me and my colleague, and the approach how to avoid these mistakes. So in summary, 4 factors are contributed to missed breast cancer: patient factor, tumor factor, technical error, and radiological factor. Patient factor, I think we all suffer from adherence of recommendation in the patient. The patient doesn't go with the recommendation that we are going to do supplemental imaging, ultrasound, biopsy. So these factors are affecting the early detection of breast cancer. Dense breast, as my colleague said, it is the most important factor as a patient factor and radiological factor. The tumor location, when it's coming in posterior part in the ribs, mammogram will not cover it. So this patient, she's a 42-year-old high-risk patient, referred to us as BI-RADS 0 for an asymmetry situated at the left breast, central posterior third. We have done a compression view for that place, and it was unremarkable. So we recommend a screening, supplemental screening ultrasound. And we found at the right breast 2 o'clock irregular hypoechoic mass, biopsied and proven as a malignant lesion. And this is one of the examples that dense breast may hidden some masses. Another young female, most of the dense breast comes from the young female. So she was at the 40 for screening mammogram, heterogeneously and or extremely dense breast. And we recommend for her an ultrasound. She have multiple probably benign masses, but it's an example of the density which may obscure small hidden masses. This patient, 64-year-old female, came for screening mammogram in 2022, which found multiple probably benign masses in the left breast, outer upper posterior third, and central middle third. She will follow up for these masses. She didn't came for follow-up, and she missed 2 years for screening mammogram. In our region, we emphasize an annual screening mammogram due to high interval cancer we suffered in our region. So we don't do biannual. We always emphasize an yearly screening mammogram. So she came in 2024 for thyroid issue. The surgeon asked for a screening mammogram for her workup. So in her workup, we found the right breast, central middle third, developing asymmetry with an architecture distortion, which when we go back forward to 2022, it was there, it was settled at that time. But because it's a basic or baseline screening mammogram, the radiologist put it as a fibroglandular tissue. So we say if she came in 2023, we might see it better and detect it, but fortunately, we detected at that time, it was 5 millimeter and biopsied, it was invasive ductal carcinoma, luminal A, which explained the low, slow tumor growth. Tumor factor, the low prevalence of cancer in screening population contribute in a higher miss rate. Mostly invasive lobular carcinoma due to infiltrative pattern, it may mislead. So this patient referred to us as BI-RADS 0 for a mass situated at the outer central middle third. Because the complexity and heterogeneity of the breast, we recommended tomosynthesis for the breast, which we found an architecture distortion situated in the central lower middle third. Ultrasound was done, biopsied, and it was invasive lobular carcinoma. So due to the infiltrative pattern in 2D, we are talking all of it in screening mammogram 2D, it will be much difficult to see the architecture distortion. Technical factor, most of the technical factor is positioning. So positioning is the most hidden problem with us. I can say perfect image is our responsibility. We have, like, if you are in the same hospital, we have to tell the technician to repeat if it's not adequate. But most of the screening mammogram, it's done in the night shift without any doctor supervising it. So training the technician, it is the most important. Other factors, incorrect underexposure or compression. So this is an example of inappropriate position, especially in the CC view, where the nipple wasn't in profile and the posterior nipple line doesn't contribute to the MLO. Of course, there is a cancer, but it's an example of inappropriate mammogram. Another mammogram, which you can see there is left breast central middle third asymmetry. But when we revised the mammo, we found there is under compression and also a motion artifact. So we advised the technology at that time to compress more and give adequate compression for the same breast. If you can see, after a good compression and putting the patient in a good position, the asymmetry, it was fibroglandular overlapping more than an asymmetry. Two examples of inappropriate position, we have a nipple nut in profile and skin folds. In the left images, you can find the inframammary fold is not covered, the muscles are not covered. So these are problem the radiologist can concern for another image. Radiological factor, most of the radiological factor, we have perceptual error. That means the radiology did not pick the mass or the abnormality. Cognitive error, the radiologist has picked up but misinterpreted, or the lesion was biopsied and discordant and the patient fall from the track that should be. Dense breast, it's the most, as Dr. Ala said, the most issue in 2D images, which it is better seen in tomosynthesis. The ACR database, they have a study which they collect retrospectively the screening cases, and they found 64% that is missed. It's due to lack of supplemental view. And the study shows tomosynthesis has become more utilized, that decrease low false positive, low recall cases, and reduce the anxiety, extra imaging, and cost for the hospital. Cancer detection rate was increased from 3.5 to 5.4 per 1,000. That is relatively increasing by 54%, which is a good modality if we want to consider it as a screening for dense breast. Another solution for dense breast, it is the contrast-enhanced mammography. A recent study, it was in 2025, published prospectively. They have 601 women. They are eligible for MRI screening. So they took these women and they added contrast mammo with the DBT, that there were increase in detection rate 10 per 1,000, which is a good number. Among these women, there were node negative and the size around 0.7 centimeter, no interval cancer by 1 year. And we see it's a good an option, quick, rather than the MRI for screening dense breast. Another example of a screening mammogram, which were unremarkable. However, the technologist, when she done the mammogram, she felt a palpable lump for this patient. We found that right breast lobulated, large we can say, but the patient, she didn't complain about it, mass and with positive lymph node. Unfortunately, it was invasive ductal carcinoma. 64-year-old female came in 2023 for a screening mammogram, and it was negative. However, after 1 year, there is density and architecture distortion seen in the left breast central middle third. Tomosynthesis, you can see if it's working. Yeah. So as you can see, the tomosynthesis were very clear to pick up the architecture distortion in the MLO view and also in the CC view. Okay. So if we can make a compare of the two images, there were a lot of technical problem that the breast was not covered very well, the nipple was not in profile, and also it was perceptual error from the radiologist itself. There were focal asymmetry in the left breast in the MLO view. The radiologist should take an added images, even if he see it or she see it in the CC view are normal. So these are one of the perceptual errors. Other causes, scanning error, satisfaction of search, and working error memory. So scanning error, as we all know, we have to emphasize about the area that should be double check in screening mammogram, like a peripectoral region, medial part in CC view, and also in the subareolar region. This patient, 48-year-old, high risk, she came as a BIRAD 0, as an asymmetry situated at the outer upper posterior third. However, when we revised these cases, we found an asymmetry situated at the CC view, central posterior third, which was not visualized in the MLO due to huge breast also, and the inframammary fold was not covered. So we done a compression view was negative. However, we done an ultrasound complementary due to the complexity of the mammogram. So we found that the left breast, 539 cm, it was in the ribs, mostly and round shape, irregular border hypoechoic mass, which was positively invasive ductal carcinoma. This case, it's at the end, 2025. You find the architecture distortion and the mass and the hyperdensity. It was at 12 o'clock, 6 a.m. But this patient, this is in 2025. She have done a lot of mammogram. Even I couldn't put the mammograms that she have done from 2016. She have done it. In 2022, it's normal. 2021 is normal. And then came 2022, and there it is, a nodule that is there. But the doctors, what we think, that there was satisfaction of search and premature closure for the mammogram due to a lot of mammograms has been gone. So they didn't pick up at 2022. Unfortunately, when she came in 2024, as we see, there was the mass. So how we can fix perceptual error, as we are doing now, training and sharing our cases, will increase our view and how we read the mammogram. The radiology should read the screening mammogram in a good office, which is quiet, a good volume that will reduce the distraction. Double reading, I think it's the basic of screening mammogram. If we don't have, as in our region, we don't have the double reading, we emphasize in AI to be the first reader or the second reader. CAD, it is controversial still because it's helpful for DCIS and calcification. It increased the detection rate by 10%, but there is 12% higher recall rate, and overall the sensitivity and the specificity in invasive cancer, there is no change. Cognitive error, around 28% of all errors. Premature closure, when the radiologist give the first impression without considering any alternative. Anchoring bias, which is the same of premature, but fixated in the first impression without or premature closure of the report. Confirmation, when you are looking for other signs to confirm your first impression, which was from the beginning is wrong. So this patient came in 2021, screening mammogram, which found multiple, probably benign after ultrasound, multiple probably benign masses and nodules in the left breast, outer upper posterior third and central middle third. After that, she came the next year, also probably benign nodules, nothing to say, the right breast, benign calcification. And then the third year, there's an asymmetry in the right breast, central middle third. Compression was done, still pliable. Ultrasound was done, an irregular hypoechoic mass, 0.7 centimeter, biopsied it was cancer. So if we go retrospectively, it's easier to see everything retrospectively. So when we go retrospectively, the density was there at the second year, but due to also satisfaction of search, anchoring bias, even technical error, the nipple was not in profile as the first and the third year, the radiologist didn't pick up. So how we can fix it? The radiologist should take the time to consider alternative diagnosis before ending the report. Double reading still is the better for screening mammogram, error reviewing and peer learning, and structure a report if we have checklist so we don't miss anything, and accurate clinical information if we can. In technology, as Dr. Ala, she already talked about for dense breast, and also my other colleague will talk about contrast enhanced mammography, screening ultrasound may decrease the missed breast cancer. So in summary, screening for breast cancer should be tailored, each individual, not only 2D, using appropriate image and consistent interpretation, and ensure ongoing training for the radiologist and the technologist, promote collaboration and clear communication. If something is missed, communicate openly, arrange for follow-up for each patient. Thank you.